Във времена на несигурност се обръщаме към най-сигурното нещо, което съществува. Науката. Науката може да пребори заболяванията, да открива лечения и да побеждава пандемии. Правила го е преди, ще го направи отново, защото когато се срещне с ново предизвикателство, науката не се отказва, тя атакува и задава въпроси, докато не намери отговорите. Това е силата на науката. Затова даваме тласък точно на науката и я развиваме. Нашите проучвания, експерти и ресурси, всички усилия са насочени към развитието на потенциални терапии и ваксини. Другите компании и академичните институции правят същото. Цялата световна научна общност работи заедно, за да се справи с предизвикателствата и всички ние използваме науката, за да помогнем това да се случи. Защото ако науката спечели, печелим всички.
Добър ден! За мен е удоволствие да открия първата сесия на Софийските дни по ехокардиография 2020 година, които поради сложната епидемиологична обстановка миналата година бяха отложени. Тази година решихме, въпреки ситуацията, да проведем с тази научна среща в този хибриден вариант и аз съм благодарна на всички наши лектори, които бяха заявили участие в програмата от миналата година, останаха в този вариант и не се наложи да направим драматични промени в програмата. Така че вие ще имате възможност да чуете, да се запознаете с основите и бъдещото приложение на миокардните деформации от А до Я в кардиологията. Благодаря на всички вас, които се включвате както на живо, така и онлайн. За мен е удоволствие да открия тази първа сесия, която е насочена именно от нормалната към патологичната деформация. Първият наш лектор е професор Кейт Маккарти от Royal Brompton Hospital, която заедно в екип с професор MYO ще покажат именно тези нарушения, които са в основата на това, което ние измерваме ехокардиографски. Kate, it's my pleasure to introduce you to the Bulgarian audience. You are welcome to our first session to analyze the anatomy and pathomorphology of the cardiac deformation. The stage is yours, and I will be very happy that you will be from in the next future in Bulgaria also.
Yes, absolutely. It's thank you very much for the invitation to participate at this meeting. It's great to once again join with you and to even meet virtually with our friends and colleagues once again. So I'll share my screen. I hope you can see that. So I am based in London at the Royal Brompton Hospital. Our department is called Cardiac Morphology, and we do a number of things, research into, and we have heart specimens or tissue from surgeries, which we work with our pathology colleagues, our cardiology colleagues, our MRI colleagues, anyone really, and we try and understand what's happening in the normal heart and in those with a cardiac abnormality, either congenital or acquired. We also do teaching and we do post-mortem work. And you can find us if you look up our Brompton webpage. So I'll start by reviewing just some of the anatomy. It's a very, very large topic. When I was researching this for the talk, hundreds of years, we've been trying to understand what is going on in the heart. It seems such a simple structure, two pumps pearled together, separate circulations, but actually even now we don't quite understand even in the normal situation, and I'll show some examples of that. So it's a spatial relationship, and we always start with the normal spatial relationship, and so that curvature of the right ventricle around that conical shape of the left ventricle. And you can see why most studies have been done on the left ventricle, because it's a rather uniform structure itself, and you can do a nice short access through it, either with your echo imaging or with MRI or CT imaging. But what can affect that? The AV junction, what's happening in the right ventricle, the left ventricle, the septum, the veins, the myoarchitecture, all these things can affect the anatomy, not only in the normal heart and from fetal to neonatal to pediatric to adulthood, but also in disease. If we just focus in on one topic, so it's a large topic, but the myoarchitecture, what is happening to that myocardium, to the muscle cells, so that they can contract and relax and pump the blood. It was actually about 1628 that Harvey, one of the first early papers showing that there's some sort of fiber orientation which is preferentially pumping the blood. And then there was papers in Stenson in 1664 where they used the term helical, and lower in 1661. And then it was a really nice paper, 1864, you can look this up, where they described, Pettigrew described that helical pattern in the left ventricular wall and we have a right-handed helical pattern in the endocardial region, and that explains how that we can get that significant pumping of blood, that contraction of the ventricle to pump the blood itself. Subsequently, there's been lots of other papers describing spirals and loops in the ventricular mass, the branching structure by Grant, and then Torrent graphs this sort of imagining of a coil-like rope so that you could undo the ventricle from right ventricle all the way over to left ventricle, and it's all one continuous structure. Technically it is. We do say right and left ventricle, but actually the myocardium is interdigitated, and so we want to be specific and say we're only measuring the right ventricle or we're only measuring the left ventricle. But you can see that there is all along the septum itself, there's that interdigitation, and you can see and you can observe in gross and certainly histologically this anti-clockwise and clockwise spiraling of the fibers. So even if we look at a gross specimen here, which we have, so this is mimicking your parasternal long axis section. So left atrium here, rather large coronary sinus, then your inflow to the left ventricle, and then the outlet, and we see where the septum is, and then we're catching the right ventricle itself. We can look on the other side of that portion of the heart itself, and we can see, is there separation of right ventricular myocardium to left ventricular myocardium? And we can't really see it there in this, the anterior side of that parasternal long axis section. And even if we look at the short axis view, this is where you're measuring. And generally, as an arbitrary decision, we take 2/3 of the septum as being left ventricle, and we take 1/3 of the septum as being right ventricle. But there isn't a layer. There isn't a layer is a very technical term, meaning that there's fibrous tissue in between the myocardium. But here we can see, when you do histology, that there is orientation. So there's different directions of the myocardium. And you can just see, I've just blown this picture up. I've blown it up so much, it's a little bit blurred, but you can see this is the left side of the septum here. And you can see the orientation around to the left ventricular cavity. And then here, the thinner and more trabeculated right ventricular myocardium. And so you can see, because we've got multiple orientations, then when the myocardium contracts and deforms, it's got multiple directions that it can do such a thing. Just to show you the opposite side, the right ventricle, again, we've got it looks a uniform structure here when you look at the gross specimen, but there is different orientations of the myocardium from epicardium, the outside, to the endocardium, the inside. And we'll have a look at that in a moment. So the myocytes themselves, they are long, thin cells, and they join to each other by intercalated discs. And so the conduction can pass, the impulse can pass from one to another. But importantly, they've got these side branches. So it isn't a uniform layer. With imaging, you don't see down to the cell level. You see to a certain level, which might actually be well over 2 millimeters with MRI, certainly. And so you have multiple branches and multiple myocytes that you're seeing in that one section. And that's why terms such as sheetlet and things like that are used, or unit, aggregated unit are used, because you can't see down to that level. But however, we can see that the overall alignment, that's the only thing you can describe in the heart, rather than different layers. And they are separated by a fibrous tissue, which is small in the normal heart, but then perhaps in disease, the fibrous tissue in between, such as in infarcts and things like that, can separate the myocardium and then interrupt the continuous contraction of that blood, of that heart rather. So here we've got a nice description in saying that you need to have a coordinated contraction of the myocytes, and it's through their continued interconnection. And we can also see that there's a range, so we can understand that endocardium to epicardium, the orientation of the myofibers changes. And the conduction velocity actually decreases from the endocardium to the epicardium itself. And if we look at a histological section, so now you can see, there is some sort of alignment or orientation. And you can see there's the right ventricle, and we can call that a third of the septum, and then here 2/3 being attributed to the left ventricle itself. And so there's no gap in between. Here we can see some fibrous tissue, and here where the right ventricle joins the left ventricle, here there's normal interdigitation. If you were to look at that histologically, it would look like disarray. The myocytes are going in all directions, but actually in this area of the heart, it's completely normal. And so it's very, very important if when looking at myocardial tissue, you know exactly where you're taking it. So is it from a uniform area, so we know the orientation, or is it from these areas where there's lots of interdigitation? So if we were to dissect the heart, you can actually, and it's been described, this is a paper that we did some years ago, that there is 3 orientations. We don't want to use the term layers because they're not separated by fibrous tissue, but there are 3 definite orientations of myocardium, which you can see, not with echo, but you can see with like diffusion tensor imaging and when you're using MRI. So you can see this is the front of the heart here. You can see the circumferentially arranged fibers in the right ventricle. But here, you can see the 2 different orientations that we've just cut. So you can see this is the innermost, which is longitudinal. And then the middle layer is sort of, again, circumferential. This is the back of the heart, so showing the same heart. And then here, we've just cut the base of the left ventricle away, just to show you grossly. You've got that circumferential arrangement, preferential arrangement of the myocardium, but inside you can see they are longitudinal fibers. And then surrounding these, we have lots of fibrous tissue, but normal fibrous tissue surrounding the myocytes themselves, which can then become increased. So you can see just in the superficial fibers, so the epicardium, then the middle fibers, and then the endocardium here. So just in the left ventricle, you can see we've got 1, 2, 3 orientations of the myocardiums themselves. And so if you're trying to understand that and see the deformation, I remember I mentioned the term helix. We still use that because in the ventricle, there's actually the subendocardial fibers have a right-handed helix, and then the subepicardial fibers have a left-handed helix. So the myocardial fiber arrangement is not just, oh, they're going in one direction or another. They are curving around each other, which aids contraction of that ventricle itself. So you can see, I've left a reference there if you want to review this, but you can see how it isn't just that there's contraction and shortening of the myocytes themselves, they are actually rotating as well. And it's the rotation of the apex that causes the contraction. So we have the subendocardial fibers, the right-handed helix, subepicardial, the left-handed helix. Then they're rotating. So we have shortening and curving at the apical side. So here I've just written, so this is the outside layers, and then here the inside layers. And you can see how there's multiple directions where the myocytes themselves are contracting and twisting. So how can you view that? You can view that with diffusion tensor imaging. So you can use the motion and the angulation of the myocyte. So when the myocyte is at 0 degrees, parallel to your electrode, it's 0. And when it turns clockwise, it's a positive. So you give that's a positive and clockwise rotation. And if it turns the other way, it's anti-clockwise. And so this is how you can mimic with you can see a very nice Hall chamber, a short axis section rather. You can see the layers and the orientation of the myocardium itself. So I have about 2 more slides, I think, 2 or 3 more slides. So this is one of the papers that have been that we worked on at the Brompton. And so you can't just take a square of myocardium and look all the way through, because you can see that we are getting different orientations which will come together and then in distally and diastally. Here we can see we've taken the block, so from the epicardium, so outside, to the endocardium, to the inside, and you can see we've cut this according perpendicular to the long axis of the myocardium. So we can follow this through to try and see what's happening in the normal heart, let alone in cardiomyopathy. And we were trying to model what we were seeing in the histology section to what you can see in actually the specimen itself. And you can see that we can mimic the layering effect of the myocardium, and the little glyphs here and the computer-generated orientation of the myocardium. You can see we have diastole and then systole. You can see the orientation has moved to more perpendicular. But when we have cardiomyopathy, there is really very little difference in the orientation of the myocardium. So you've got those 3 layers, but then how do they act? And then how do they act in disease? So my last slide, I think I'm slightly on time. So you can see we can't actually, we're not describing one myocyte. We are describing a sheetlet, a unit. And that's what you see with your echo, with imaging, with CMR, with CT imaging. You're seeing a whole number of myocardium, which are preferentially in one orientation. And you can see here in diastole and then here in systole, where it will expand, but also rotate and twist. So it's a large topic, but I just wanted to introduce some of the, if you're looking up any of these papers, that myocardium isn't a uniform structure, and that in such that there isn't layers, there's orientations, but even then it changes from apex to base. We've got to think that they are shortening, thickening, and rotating during contraction and relaxation. So I think I'll finish there, so I don't go over time. So thank you very much.
Thank you, Kate, for your very interesting and very gentle presentation of the anatomy of myocardial deformation. I think there is there any question from the audience to Professor McCarthy? Dr. Shubani?
Or if not, I will wait till the end of the session, just so that there's I don't go into the
if we have some questions, we will continue on the end of with the session with the questions. So thank you so much once again, and we will continue with the next speaker.
Удоволствие, колеги, да поканя доцента Христова, how to measure the overlaid cardiac deformation.
Аз ще продължа с това, което професор Макарти обясни във връзка с миокардните деформации и с една от най-първите техники, която беше въведена тук, именно по отношение на оценката на миокардната деформация. И това е приложението на тъкания Доплер. Така, миокардната деформация, както разбрахте, определя именно от механиката, която се осъществява от движението на миофибрите по време на съкращение и на разпускане на камерата. Това е един процес, който включва тази деформация като един нормален белег на функция на камерата. Именно чрез този сложен въртелив механизъм на удължаване, на съкращаване на камерата, едновременно завъртане и усукване на камерата, се осъществява енергията, с която сърцето изтласква кръвта. Това е в основата на именно на разбирането на миокардната деформация като функция. И това е една нормална функция, която ние можем да мерим ежедневно в практиката. Именно през 1996 година проучванията, които започнаха от колектива на Мирски, положиха основата на тази миокардна деформация като оценка в едно измерение чрез приложението на тъканния Доплер. Няма да се спирам на този слайд, който беше добре обяснен от професор. Всички знаете ефекта на Доплер в физиката, който дава възможност именно да преценим какво е отражението на движението по отношение на сигнала, който се получава именно в ехото. Именно удължаването на вълната и намаляване на честотата е в основата на оценката на движението на Доплера по отношение на тъканата деформация. Така че ефекта на Доплер, който е установен още получава се някакво ехо при мен. Този ефект на Доплер именно стои в основата на оценката на тъкания Доплер при изразяване на деформацията. Именно миокардната функция чрез по време на изпразването и налягането в камерата ни дава този тънък механизъм на помпена функция. Деформацията, казахме, че е нормален процес, който именно дава оценка на промяната в дължината на това съкращение по отношение на глобалната функция на камерата. По принцип, винаги имаме един градиент, който в базата е значително по-нисък по отношение на скоростта и този градиент се увеличава към върха в лонгитудинална посока по дължината. Така че градиентът, който ние определяме чрез оценката на скоростта в тъкания Доплер, дава отражението върху времевото измерване на този градиент и като деформация се изразява като стрейн. Така че стрейнът е показател, който именно определя този момент на деформация, която настъпва. Знаете всички, по време на съкращение на камерата, тъй като сърцето е разположено в една координатна система, ако си го представим в пространството, която е с три равнини на разпространение на съкращението, по време на съкращение и по време на изтласкване на кръвта, ние имаме съкращаване в лонгитудинална посока, задебеляване в радиална посока и също съкращение, което е в циркумферентната посока. Обратно, по време на вече на диастола, тогава, когато се осъществява процеса на пълнене на камерата, ние имаме удължаване в лонгитудинална посока, изтъняване на камерата в радиална посока и също удължаване в циркумферентна посока. Едновременно с тези допълнителни механики, които се оценяват по време на този процес на пълнене на изпразване на камерата, имаме допълнителното завъртане, което ни дава допълнителната енергия, която се осъществява по време на деформацията в камерата. Тези две основни компонента на съкращение на лявата камера, именно по време на изпълване на камерата, по време на промяна на тази геометрия и по време на изтласкването на кръвта чрез съкращението, оформят двата основни механизма на деформация и съответно регионалните промени, които ние можем да осъществим чрез оценка на стреса на стената, чрез съкращението и удължаването и задебеляването на стената, както по време на изтласкване, на injection, и деформацията, която се реализира след като вече е приложена тази енергия. Най-накрая, като резултат от тези оценки, ние имаме оценка на стреса чрез стрейна и промяната в деформацията, която се изразява в този стрес на стената и като крайен резултат именно промяната в деформацията или промяната в стрейна. Така, като основно определение на миокардния стрейн, чрез тази деформация, която ние оценяваме, е сумата от деформациите в един определен обект, причинени от приложената начална сила или стрес прямо първоначалната форма на промяна. Или имаме съответно лонгитудинален и циркумферентен стрейн, които се проявяват с скъсяване по време на началната деформация, и радиален стрейн, който съответно води до задебеляване на миокарда. Това е най-общото определение на стрейна като уравнение, което ни показва как ние изчисляваме тези промени в времевия интервал. В годините беше наложено две понятия по отношение на стрейна. Това е така нареченият ланграниен стрейн. Първичната деформация спрямо приложената сила или енергия и удължаването, което се отчита в момента. Това е така нареченият ланграниен стрейн, който именно може да бъде изчислен чрез тъкания Доплер. Но ако се гледаме допълнително в промените, които настъпват, този стрейн, отнесен към времето, в което се осъществява тази деформация, може да бъде допълнително удължен в един момент преди затварянето на аортната клапа, тогава когато е пика на систолата. Именно тази малка деформация, която се получава допълнително и ние не можем да хванем с тъкания Доплер, е така нареченият еурелиен или темпорален стрейн, който е малко по-точен в оценката на деформацията. Именно този стрейн може да бъде осъществен чрез промените, които се осъществяват чрез миокардния velocity imaging. По отношение на лангранния стрейн, той може да бъде съответно отнесен към spectral tracking, към MRI, MMOT при оценката в промяната на деформацията, както и вектор velocity imaging, който е друг вид на двуразмерният spectral tracking. Казахме за регионалната функция, също може да бъде оценена чрез тъкания Доплер. Тя съответно се определя в лонгитудинална, радиална и циркумферентна посока в тази координатна система, като деформация на стрейна в тези три моменти. Кое е скорост и кое е деформация? Преди всичко, когато работим с тъкания Доплер, ние мерим скоростите и промените, които се получават в движението на стената или дисплейсмента. Пробният обем обикновено определя деформацията именно в една точка. Това е характерното за тъкания Доплер. Затова, когато ние прилагаме TDI или тъканен Доплер за оценка на деформацията, трябва да знаете, че това е деформация в едно измерение, в една точка, която обикновено е с ниска скорост на движение, но за да постигнем достатъчната амплитуда, която да отговаря на сърдечния цикъл на съкращение, ние трябва да работим на значително висок фрейм, който трябва да бъде над 160, но под 240, за да се избегне ефекта на лайзинга. Най-простото обозначение на този тъканен Доплер като MMOT цветен Доплер е именно тази цветна карта, която се получава. И тя дава възможност да определим по време на систола и на диастола какво е деформацията и движението. Обикновено, за да се получи този образ, ние използваме висока пространствена и времева резолюция по време на изобразяването на честотния сигнал. Така че тъканният доплер като възможности на анализ ние можем да получим във вид на pulse wave, можем да имаме във вид на цветен 2D образ и цветен M-мод. Всичките тези модалности са изображение именно на тъкания доплер за оценка на анализа на деформацията в една точка, в едно измерение. 2D цветният доплер именно представлява презентация на тази миокардна деформация чрез оценка на скоростта в сивата скала от двуразмерният образ, като съответно ние посочваме посоката, в която се променя скоростта по време на движението на миокарда и чрез увеличаване на тази пространствена резолюция можем да получим анализ в различни точки и различни сегменти като презентация на тази деформация. Знаете, Pulse Wave тъканен доплер ние използваме чрез оценка на скоростите на движение на миокарда. Това става и е валидирано по отношение на стойностите, които се получават от миокард на ниво на митрален клапен пръстен, което е един много добър показател каква е лонгитудиналната функция по отношение на контракция и релаксация. Можем да мерим в тази посока както скоростите, така и чрез използването на този единичен обем, чрез придвижване по отношение на миокарда, да определим съответно какво се случва с промяната в скоростите при различни състояния. Най-общо, това, което ние използваме от TDI, е именно тази промяна в деформацията по отношение на оценка на диастолната функция, която се получава на ниво на митрален клапен пръстен. По отношение на тъкания доплер и като приложение в ежедневната практика, именно скоростта на движението на миокарда, съответно, което корелира в степен на миокардната деформация или strain rate като време, дава възможност да определим именно каква е контрактилността или дипидите на камерата и от оценката на тази степен на миокардна деформация, изразена в процент, дава именно регионалната деформация или стрейна на камерата, което корелира с ударният обем съответно. Методите, които могат да оценяват тази деформация по отношение на използването на доплер, това са Doppler Tissue Imaging, който дава възможност именно да оценим тези моментни нарушения по отношение на промяната на скоростта, чрез оценка на strain rate и на вече полученият strain като показател от този параметър. Спекъл тракинга, който ще бъде предмет на следващата презентация след мен, е именно възможност да се избегнат многото ограничения на тъкания доплер на TDI, като в зависимост от ъгъла на инсинуация на сканиране, който използваме чрез промяната на дебелината на стената, както и по-добра възможност на регионалната функция. Винаги трябва да знаете, че този миокарден градиент на скоростите е запазен както при оценка от TDI, така и при спекъл тракинг. Така че оценка на миокардната скорост на деформация или myocardial velocity imaging, ние използваме първо оценката на скоростта, от която получаваме съответно промяната, която се реализира като в времеви интервал, като strain rate, и от производното чрез интегриране във формула се получава именно стрейна като процент. Кривите, които ние познаваме в нашата практика, и които измерваме като миокардна деформация, именно на стрейна, който е с негативен знак по време на затварянето на аортната клапа или в края на систолата, може да бъде оценен в различни времеви интервали на един сърдечен цикъл. За по-точно оценка на диастолната функция можем да използваме кривата на стрейн рейта по време на диастола с два пика, която е по време на ранното пълнене и на късното пълнене на камерата. Нормалните стойности, които са в съответно различните сегменти на ниво на митрален клапен пръстен, съответно на латерално-септално предна и задна стена, по време на систола и на диастола и съответното съотношение. Виждате, те са близки, около 10-11 за различните сегменти. По отношение на глобалният стрейн, това, което беше показано на ниво на всички нива като глобален, различни стени на ниво апикален, среден и базален сегмент, публикуван от професор Томас Марвик през 2009 година, е един много добър анализ, който ни дава възможност да корелираме нашите данни по отношение на наличие на нормална деформация или патологична деформация. Или може би това, което е основното и трябва да запомните от всички тези методи за оценка и различни стойности на скорости и на стрейн рейт, е предимно, че скоростта на деформация се движи между 4,1-4,2 при мъже и при жени. Стрейн рейтът е съответно по време на затваряне на аортната клапа между 1,6 и нормалният стрейн съответно при жени винаги са по-високи тези стойности. Това показах и последните анализи от НОРЕ. Именно при групата на жените са винаги с по-високи стойности, както за лява камера, така и за дясна камера. Ниво на стрейн от тъканен доплер, нормални стойности минус 21, минус 22 за жени съответно. Клиничното приложение ще бъде съвсем кратка, с няколко слайда, вече оценка на диастолната функция чрез корелиране на кръвотока на ниво на митрална клапа и скоростите, които анализираме на базално ниво. Можем да направим една регионална систолна оценка, особено полезна при пациенти, които са прикарали миокарден инфаркт. Винаги имаме понижение на скоростите. Това е един пациент с предносептален инфаркт. Понижение на скоростите на зоната, където е съответно с исхемия. Можем да направим оценка на диастолната функция, именно чрез приложението на два от показателите, които са за оценка на глобалната функция твиста и антвиста. Това ще бъде предмет на друга лекция, аз няма да се спирам толкова подробно. Именно по време на този процес на развъртане на камерата можем да оценим антвиста и твиста по време на съкращение на камерата в момента на затваряне на аортната клапа и между затварянето на аортната клапа и отварянето на митралната клапа като момент, в който ние можем да оценим за диастолната функция. Така, като основа от всичко, което съм казала до тук, Doppler TDI, Spectral Tracking или Doppler, тъканен Doppler е метод на оценка на миокардната деформация, който се влияе от ъгъла на сканиране. Винаги трябва да търсим някакво съответствие между съответната скорост и сигнала, който се получава като деформация. Работим винаги на висок фрейм, за да можем да получим съответната картина. По отношение на съпоставката на двата метода за оценка, предимствата, които се по отношение на едната използвана техника и на другата използвана техника, съответно са доста. Зависи от това вие каква възможност притежавате към различните методи на оценка, но винаги трябва да знаете, че когато използвате TDI, това е едноразмерен начин на оценка. Измерванията са зависими от ъгъла на сканиране. Трябва да ограничим съответно пространствената резолюция и да увеличим времето, което ние съответно използваме за анализа. Ще видите това по време на нашата практическа част. Трябва винаги да се съобразявате с образа, който анализирате, и методът, ако не е добре, съответно съвпаднал между различните анализатори, може да имаме доста голям байас между резултатите. Като заключение, винаги едната методика намира предимство пред другата методика. Това от какъв начин на анализ ще се възползвате вие. Преди всичко в последните години Spectral Tracking ехокардиографията се наложи като един бърз и доста обективен метод за оценка на деформацията, но предимствата на тъкания Доплер преди всичко могат да ни покажат, че тук ние можем да избегнем този момент на тетеринг, който се среща значително при Spectral Tracking ехокардиографията. И е много чувствителен маркер, който може да ни даде началните функционални нарушения, които се наблюдават в нарушенията на миокарда. Благодаря ви за вниманието.
Колеги, някакви въпроси, коментари? Много хубаво, Алекса, много е подробно. Аз се бих само, не знам, сигурно ще стане ясно, той 2 дена само с това ще говорим, ще видите, че когато говорим за тъканен Доплер, ние разпитваме скоростта на мускула. Това е както го правим. Както нормалния Доплер, ние разпитваме скоростта на кръвоток, с тъкания Доплер разпитваме скоростта на мускула, което някъде 10 пъти по-малко, отколко, когато мерим, да кажем, 1 метър в секунда. От нормалния Доплер ще видите в тъкания Доплер някъде 7, 8, 9, 10, 11 см в секунда. Това е съществена разлика, разбира се. И другия момент, който е важен, което много подробно каза Санта Христова, че когато разпитваме с Доплер, той зависи от ъгъл. И когато ъгъл е голям, ние получаваме много малки скорости или минимум скорости или 0. Докато когато ще видите, когато работим с Spectral Tracking и разпитвам, правим деформацията, той не зависи от ъгъла. Заради това ще видите, ако четете публикациите, сега много рядко виждате някаква публикация, която правят стрейна от тъкания Доплер. Защото той първо взема скорост, от скоростта после мери разстоянието и оттам отшъслява деформацията. Разбирате ли? Това е голямата разлика. Така че много рядко ще видите стъканен Доплер вече за стрейна. Ще го видите, разбира се, за скорост, това, което говори, за разпитване на скоростта на мускула на различни точки от това. Така че това е съществена разлика в практика. Това ще стане ясно сигурно в хода на 2 дена. Още в нещо коментари, въпроси, колеги? Тъканен Доплер сигурно всички работят, ама стрейна малко хора от вас сигурно работят и за това още нямате опит.
We will continue with our next guest speaker. This is Professor Shantanu Sengupta, and he will speak about the non-Doppler based strain methodology and how to evaluate the cardiac deformation. Professor Sengupta, you are.
Thank you so much, and good afternoon to everyone. I am Shantanu Sengupta. Thank you, Professor Ristova, for such a nice invite. I always wanted to come to Sofia, but I think even this year it would not be possible. So I have been given a task of looking at the cardiac deformation from 2D or 3D strain, and my previous 2 speakers have done my job pretty easy. So this is what I would like to tell you, that where am I from? I'm from a place called India. So this is India, and I'm in the center of India, which is called Nagpur. And I hope that you all should come to Nagpur, and it is the capital of tigers. So you'll have a lot of tigers in this part of the country. Anyways, so let's go ahead with the thing. So my first speaker, Professor Mecca, she told me about the structure and the anatomy of the heart. So the heart is a high-performance pump, and this is how we look at the heart when we open it up. This is a surgeon's view, and you yourself can see that the heart is twisting. So it's an organ which weighs around 300 grams and pumps around 8,000 liters of blood per day at rest and much more high in activity. So it's a very high performance pump, and it is all because of the wriggling motion of the heart. This is the apex, which is moving anti-clockwise, and it is equivalent to, in terms of mechanical work, representing a lifting of around 100 pounds of weight 1 mile high. So it is a fantastic structure, and the apex is moving anti-clockwise and the base is moving clockwise. So there is a continuous churning which gives the vortices in the heart, and it gives the the stroke volume or cardiac output, whatever you want to say. And the interesting part about the heart is that the LV apex is the most thin part, and it is the thickness of the heart goes less from the base to the apex. That's why Professor Risto was telling that there are some changes in the regional values of the strain, and this cone-shaped thin flexible apex gets suspended to the base where the aorta is there, and this is the reason that there is a lot of twisting motion of the heart because of the helical oriented myocardial fibers. And this is a high confocal macroscopic view showing that if we cut one muscle fiber, the epicardial fibers and the endocardial fibers also move in counterclockwise direction. As you can see, the epicardial fibers are moving in this direction, while in that phase, the movement is in the other direction. So this is very important to understand, because once this twist or the churning or the wriggling motion gets altered, you get a lot of problems. You get dilated cardiomyopathy, you get ischemic cardiomyopathy, you get all kinds of problems of heart failure, which is the end result of the disease. Now, we have been able to look at the heart, and as we were saying, that the base has a right-handed helix, while the apex has a left-handed helix, and the angulation is quantified by almost around 60%. So this is what is the geometry of the heart, and we had an anatomical distribution which was there. So the components of cardiac deformation has been simplified by looking at the longitudinal fibers, which are predominantly subendocardial. So you have the fibers which are arranged inside. They are the subendocardial fibers. They are arranged in the longitudinal fashion. You can look at them by the apical views, apical long axis, 3-chamber, apical 2-chamber views, while the subepicardial fibers, or the fibers which are outside, they give you the circumferential fibers and the radial components. And this all can be mapped by looking at the various movements of the heart by an echo. The apical long axis view gives you the longitudinal strain or longitudinal fibers. You have three views: apical long, 4-chamber, 3-chamber, and 2-chamber, while 2-chamber views or parasternal short axis views gives you circumferential and radial fibers. And this we can do from any machine nowadays. Now, looking at the fiber orientation, as I said, we have to remember that longitudinal fibers are always subendocardial, which gives you the longitudinal strain. So any cardiac pathology like systemic hypertension, subendocardial MI will always give you strains which are lower earlier. So the circumferential radial fibers are generally preserved, while circumferential fibers are subepicardial oriented, which are represented by circumferential strain. They get involved first by a problem which which engulfs from outside. So the classical example is, let's say, constrictive pericarditis. So constrictive pericarditis, the circumferential strains go first down, but the longitudinal fibers, which are subendocardial, may be preserved. So that's the way you'll try to look at. But if the person has a transmural, involving both the subendocardial and the subepicardial segment, like classically seen in a transmural MI, all the fiber orientations go down. So that's the way you should know the orientation of fibers. And remember, we also have, whenever we are going to talk, is we are going to only talk in clinical practice is about longitudinal fibers, longitudinal strain, because this has been validated only by 2D. The 3D strains are not yet validated. The circumferential strains or the radial strains are not validated. So that's why they are not yet in clinical practice. But of course, if you want to do a research, you can always do a lot of things. And remember, we always look at global longitudinal strain, the complete whole thing, because regional strains are also not validated. Regional strain values should not be told, but you can always quantify, you can always tell about the regional strain pattern. So how is the apex, whether they are moving less or the base or something like that. So regional strain values should not be given, but regional strain pattern should be told. Now, there are various ways you can do it. Remember, this is every machine gives you different names. You have EchoPack so G has one machine, Siemens gives you other names, Philips gives you other names. But at the end of the day, they're all measuring what is called a 2D strain. This is not Doppler strain because this is 2D strain because this has been uniformly validated. And remember, you always start or the machine. Now these machines are now automated because the use of artificial intelligence, but you generally start with an apical 3-chamber view because you're looking at longitudinal strain. The reason of identifying by apical 3-chamber view is that the machine automatically takes the time of aortic valve closure, because the timing of aortic valve is the need to identify what kind of a phase you are looking at, whether it is systolic phase or a diastolic phase, early diastolic and late diastolic. And you look at all the 3 dimensions in 2D strain. There is apical long axis view, where there are 3 chambers, apical 4-chamber view, and apical 2-chamber view. And this is what you get is a nice red-shaped pattern, which is nothing but, which is called bullseye imaging, where you get all the values and the machine gives you an average of the value, which is called the global longitudinal strain. When we were learning strain earlier, we used to do it manually. We can still do it manually, but there is a lot of automation which has come up, and it does help in understanding what is global longitudinal strain and what are the values. Now let's try to understand in a very simplified manner what is a normal global longitudinal strain. So this is a normal person where we start with the parasternal long axis, short axis, but directly go to all the 3 values, and you get the normal value. The normal value which has been quantified, which has been accepted in the chamber guidelines, is around -19 and above. So it should be -19, -20, -21. So it is a minus thing because whenever there is a contraction, there's a shortening, it is defined let's say this is our probe. The probe is here, so there is a contraction, so there is a movement which is away from the machine, and you get a negative waveform. The negative waveform indicates that there is a shortening, and this shortening gives you waveforms, and they have quantified to -20. Anything less than -19, -18, -15, is a pathological problem. There is some problem, but anything more than -19 is supposed to be a normal thing. And there are various ways of looking at the strain. This is a quad view. These are regional views where you get regional value. This is a bullseye value where it divides again by AI the segments as anterior, interseptal, posterior. This is the lateral wall. This is septal wall, and everything is divided as basal, mid, and apex. And this is the apical cap. These are the ways, and these are the regional values. Remember, regional values should not be taken into account. It is a regional pattern which is important to understand. So this is about normal 2D strain. Now these are more images about myocardial work index. I will not go into detail because we can have a lot of discussion about that. Now coming to the next is how this is going to affect our day-to-day clinical practice. Now, before going to the abnormal or any pathology, there is something called 3D strain also. Now, 3D strain has come up in a lot of machines. All machines are providing a 3D strain. But let me tell you, 3D strain is not yet validated. It is not in the guidelines. It is still in the research phase. What it does is you try to get a strain value by a probe which uses an augmentation of parameters from the 2D acquired. So the 3D image is acquired from a 2D thing, and that is the problem where you are getting these values. And the 3D strain again incorporates longitudinal strain, radial strain, and circumferential strain, everything together. But there is a catch. The catch is the acquisition of the strain values are from a 2D oriented image. But the advantage of this information by 3D strain is that you get all the volumes, you get LV mass. Now the LV mass derived from this 3D strain has been shown to be very effective, and then you get this kind of curve. This is nothing but a systolic shortening followed by a post-systolic relaxation, which is there. Remember, 3D strain is still in research phase, and if you want to do it, it also gives you a bullseye image which has got values. But if you ask me what is the 3D strain normal value, I will say it changes with the machine which you are using it. It is not yet validated. Now, I do use 3D strain? The answer is yes, I do use it, and answers as because till you get the volumes, till you get the LV mass, it has got fantastic. It gives you very good information. Now, coming to the various values, why is it not moving? I think a lot of data is. Yeah. So this is a patient who had chest pain and had come had minimal ECG changes, and as you can see, we take all these values, and this was a pattern of on a 2D strain which was there. Even before you get a trough values, you can see that the anterior part of the septum along this segment came out. There was some changes which was not very much evident on an echo on an apical fourth chamber view. So this patient was immediately taken for an angiogram and had an LAD problem, and it was stented. So the pattern of angiogram or a pattern of strain imaging does help in a clinical practice on a day-to-day basis. Now, coming to the next, I think there is a lot of data. So this is how the 3D view, 3D strain goes. You get volumes. I'm just trying to show you a couple of nice images. The second thing, so this was a patient who had anterior wall MI, and as you can see, this anterior part of the segment was hypokinetic. He was in florid chest pain. The drops were taken, but before we could get the values, you had a regional deformation which was compromised, and the patient had a angiogram, and his LAD and left circumflex both had a problem, and he was immediately taken for a PAMI. So a regional value is not good, but a global pattern and a global longitudinal strain is always helpful in an emergency, and we do this on a regular basis when the patient is coming. Now, let's I think a lot of images are there. One sec. Yeah. So this is the same patient where his 3D was taken, showing more information. Now, this is a case of dilated cardiomyopathy. This patient had a very poor LV, and as you can see, it was a completely dilated LV. And we did do a strain imaging, and the strain imaging gave you, I think, a value was. It was taking a lot of time to load. 1 second. Okay, so it's loading. So 2D strain. I'm just moving it fast over here. So as you can see, the pattern of the strain, the global longitudinal strain was around 1.6 minus 1.6. As I told, it was highly affected. Now, this is an important case where the patient came with heart failure. As you can see, had a good LV function, which was maintained. IVC was full. This was rapid tall E by A more than 2, and this was the hepatic reversal. So whenever this kind of patient comes, we always do the myocardial mechanics. And as I was saying, so this was an important paper by Partho this was the patient of constrictive pericarditis. And I just want to tell you that in constrictive pericarditis isolated, the longitudinal strain will be preserved, but the radial and the circumferential strains goes impaired first. While in rather the other way, in because in what happens in constructive pericarditis, the fibers are getting affected from outside. But if there is restrictive cardiomyopathy, the first thing goes is longitudinal strain. So restrictive cardiomyopathy is a problem of muscle. So the first thing to go is longitudinal strain, while the circumferential strain or the radial strain will be preserved. But if you are having heart failure, and if you are having both restrictive, both the longitudinal fibers and the radial fibers going down, then it is a problem where there is a constriction along with restrictive cardiomyopathy. So this is the only way where we can pick up constrictive pericarditis at an earlier stage, and you can prevent them by giving colchicine and other kind of drugs. Now, role of strain imaging in valvular heart disease. Now, this is the study we did in mitral stenosis. Mitral stenosis is a big problem in the developing countries and also in India. And we saw how does the strain behave before BMV and post BMV. And we documented that irrespective of the LV ejection fraction, irrespective of the strain values, every patient of severe mitral stenosis should be given a benefit of BMV or a PTMC if the mitral valve is pliable. We had this group of patients where at baseline their strains were around minus 9.9, and as I said, normally it's around minus 19, and their strain do improve after the mitral valve is opened up with a global longitudinal strain improvement of almost around 4%. So importance of strain in mitral regurgitation or aortic regurgitation? The answer is the recent guidelines have not yet incorporated strains in patients who are having severe MR or severe AR but are asymptomatic. So I'm talking about asymptomatic severe MR or AR, a condition where the patients generally don't come to us, they don't report, but there is a lot of work which has shown now that if you are having a patient who is asymptomatic but has severe MR, a global longitudinal strain of anything less than minus 18 has an independent predictor of post-op LV dysfunction. So there is a role of strain analysis in subclinical LV dysfunction where the LV is preserved, patients are asymptomatic, but the strains are going down. And in organic MR, who are asymptomatic, the value is minus 18. In the same, there was a second paper that in MR, if the value is less than minus 19, then it is a major independent predictor of long-term LV dysfunction. So this is the thing which has been, which came in JACC imaging, that if a patient is asymptomatic primary mitral regurgitation, if the volumes are going up, you can surely go for surgery. But if the patient doesn't have the volumes going up, then assess the GLS. Anything going less than minus 19, send the patient for an early surgery. They are going to do better. This is for asymptomatic severe AR, and the value is minus 18. But if the values go below minus 14, then it is associated with poor outcome. Now, again, in severe AR, you have to look at the RV side. The point what I'm trying to tell you is that strain has a robust information which can be given on patients who are still asymptomatic, having asymptomatic LV dysfunction. And I just would like to tell you that the application of strain has been so tremendous that even in cardio-oncology, which itself is a separate entity, we can always discuss, it does pick up subtle findings. Remember, 2D strain, global longitudinal strain is validated, should be accepted. Radial strain, circumferential strain is on research thing. They give you the subepicardial fibers orientation. And regarding 3D strain, if you have the machine, you should start using it, but should not comment upon the value. Anything, it gives you good volumes and also the LV mass, but regarding the value, with which different vendors, the vendors give various different variable information. And let me tell you, this is a echo imaging of a tube of the heart, which was picked up at 7 weeks and 8 weeks. And there are changes which do start normally on a systolic and diastolic information. This is the apex, as you can see, the apex movement is very minimal, and this is from where the aorta starts. And this movement of the heart gives you all kind of churning and action, and heart gives you a very high performance organ. Thank you so much.
Thank you so much, Professor Sengupta, for the very nice presentation. Колеги, имате ли въпроси към професор Сенгупта? I would like to ask you something, because you are one of the very experienced author, especially for the speckle tracking. How do you think in the near future will be the ejection fraction replaced from the global longitudinal strain?
So the question is whether ejection fraction will be replaced by global longitudinal strain. The answer is, I think nobody can replace anything. They are basically complementary. And what I can suggest is that global strain has got a phenomenal advantage in picking up subclinical LV dysfunction. I didn't mention about two things. I didn't want to make it more complicated. Was about the right ventricle and also about the vortices, because the future is going to be imaging the vortices, and there are a couple of studies. I mean, we have already done a few studies. The point is, will it replace ejection fraction? The answer is no. So every time I do imaging, I always complement by playing Simpson's ejection fraction and get also strain values, that to global longitudinal strain. And I think they are already complementary. Nothing can replace or change, because both are very important.
Okay, but we have critical value that it's important to know, especially with the patient with the valve disease, when to send the patient for the cardiac surgery also, and not to waiting to reduce the ejection fraction. You agree with that?
Absolutely, yes. Absolutely, yes. Yeah.
Okay.
Okay. Dr. Klaus, are you here?
Yes, I'm here.
Yeah, okay. Dr. Klaus, cardiac mechanic, we walk with now from MRI, please.
Okay, thank you very much for the invitation and the introduction. It's a real pleasure for me to be able to speak at your nice conference. Of course, it would have been much better if we would have been able to visit your nice city of Sofia, but I hope in the future that will be possible again. So you've asked me to talk about cardiac mechanics and what we learned from MRI. I have no conflicts, and I work at the Department of Cardiovascular Science of the University of Leuven. Sorry. Yes. So I think one of the important questions, and a lot has already been addressed by the previous speakers on the fundamentals and how to measure. But if you adopt the technology, I think one of the important questions, which is sometimes forgotten, is that we should think why we want to measure things. Why are we in need of measuring myocardial deformation or measuring myocardial function? And I want to illustrate this, and it has been told by the previous speaker already, but I think it's important. I want to illustrate this with a cartoon that has been around for several years and has been nicely shown in this clinical update in the European Heart Journal by MYOARCHITECTURE and Scott Solomon. And in fact, the reason to look at deformation components is that when you monitor patients in the evolution to heart failure and with reduced ejection fraction, you cannot use ejection fraction as the sole parameter of how this heart is functioning, because ejection fraction will stay for some time, will stay constant and normal. And of course, that's what we usually call subclinical entities. We cannot pick up these subclinical changes by looking only at ejection fraction. The paradigm that is used, that is going on, is that to maintain this ejection fraction constant and normal, there are different strain components that react in different ways. And what you see here in the cartoon is that actually circumferential strain would increase if you, for instance, think about hypertension, but longitudinal deformation would decrease. And in that way, the two components together could act to keep the LV ejection fraction constant. So this is kind of the reason why we should look at the myocardial deformation and the myocardial function to monitor patients in their progression to true LV pump dysfunction. Now, it's also surprising that strain measurements, although they are around for now like more than 20 years in clinical practice, have not entered a lot of the guidelines. As was said before by Dr. Sengupta, of course, it cannot replace ejection fraction. I think the cartoon of the previous slide just shows this because a lot of the guidelines focus on where the LV dysfunction already starts to deteriorate. And at that point in time, longitudinal deformation has only incremental value towards LV ejection fraction. Where it has a lot of value is indeed in this first remodeling stages. But there have been some larger studies that showed indeed an independent predictive power for longitudinal function. Either way you measure it, you don't have to measure it really as a speckle tracking strain or a strain trace. Longitudinal function can also be measured by what we know as the MAPSE or the TAPSE. That's also a measure of longitudinal function. And if you look at this kind of longitudinal function, it has been shown in large trials that it is an independent predictor of heart cardiovascular events. This was a study in the MESA trial that showed that reduced longitudinal function had indeed predictive value to show more heart events. Then there was also the Paramount trial that was in patients with HFpEF, where certainly longitudinal strain should have an impact, as seen from the previous cartoon. And there it was associated with higher NT-proBNP. So it really shows that myocardium is challenged in these patients, and that was shown by a reduction in global longitudinal strain. And I think one of the newest application, and that's the results of the SECURE trial, and where probably, and strain is entering there, the clinical guidelines, it is to guide the initiation of cardioprotective therapy in cardio-oncology. And it has been shown that in this SECURE trial, which was a randomized trial that did monitoring of reduction in cardiac function during treatment, that had two arms. There was one arm that looked at ejection fraction. There was one arm that looked at global longitudinal strain. And the major outcome of the trial was actually that the change in ejection fraction or the reduction in ejection fraction in both arms were the same, but with monitoring based on global longitudinal strain, cardioprotective therapy was initiated a bit earlier and had, in that sense, resulted in a lower reduction in ejection fraction at 1 year. And it's probably an area where longitudinal strain will play a major role in the future. Now, that's some thoughts about why we would be interested in doing deformation imaging. Now, if we go a bit back to history, people have always been, from a physiological point of view or a pathophysiological point of view, interested in myocardial mechanics and looking at how the muscle reacts to certain challenges that is given to the heart, and how actually the contraction of this muscle can make that we have a constant and stable cardiac output during rest, and how we can increase this cardiac output if needed during exercise. And before, in like 1960s, 1970s, 1980s, where a lot of physiology research was done, there were only lab techniques. And the lab techniques were to implant radio-opaque beads that could be followed on Röntgen, on the RX. in the myocardium, and in that way show the motion of the myocardium, or implant like sonomicrometry on the surface of the heart, which are crystals that talk to each other with ultrasound and can measure distances between these crystals. So measuring myocardial mechanics in terms of deformation was quite limited, since it required open chest preparations. And of course, there are very, very limited patient studies done in that way. There are some transplant patient studies where beads were implanted, but pre-transplant, but that's more or less it. So that changed all in 1988, when Zerhouni and colleagues in Johns Hopkins were developing cardiac MRI and were developing cardiac MRI tagging. And they found a way to apply, and you see that in this image, to apply tags non-invasively on the tissue that could be followed during the cardiac cycle. And that's where non-invasive deformation imaging started. And at that time, we needed very dedicated acquisitions. So that means special sequences or special kind of scanners or modalities on scanners that could capture the motion of the myocardium. And once you have the motion of the myocardium, of course, if you make a gradient of that motion, you can capture the deformation of the myocardium, and in that way measure the myocardial mechanics. So it started with MRI, actually, to do it non-invasively, and then different techniques were developed, like strain-encoded MRI. But then the major, more clinical application, or towards clinical application, came, of course, when the engineers in Trondheim, together with their spin-off Ving method, that is now GE, developed tissue Doppler imaging, where they could adapt the filters of a normal blood color Doppler acquisition to acquire the velocities in the myocardial walls. And that was around 1998, 1999. And that was really the start of a new area in deformation imaging, where first tissue Doppler imaging was developed to strain rate imaging, and so on. But that all needed dedicated acquisitions and was still quite not accessible to everybody. Now, what we have seen in the last years, in the last 15 years, more or less, is that this whole acquisition shifted from dedicated acquisitions to dedicated post-processing on the regular images that we acquire in the EchoLab. So in the EchoLab, the regular B-mode images, 2D, also 3D, as has been shown by the previous speaker, and the regular cine imaging on MRI. And by processing these images and doing tracking techniques, we can also measure the cardiac deformation. And that is really has been an important step in the evolution, because that means now that we can also do retrospective analysis of acquired images before, but also that it doesn't interfere too much with clinical practice, since you are doing this imaging anyway, and you can, to more or less extent, reliably image the myocardial mechanics. Now, just a few words on techniques. And now I focus more on MRI, of course, which was the topic of the talk. There are several techniques, and you should maybe be aware of it, to measure the deformation in an image. One major class is what we would call elastic registration. And what elastic registration will do is it will try to map this end-diastolic image, it's a 4-chamber view, end-diastolic, to a next point in the cycle. Let's say this is mid-systolic, by deforming the image elastically. And you see the grid on the image, and it will try to deform this grid such that this image fits the image a time point later in the cycle. Typically, for all techniques, this is done in a multi-resolution approach. First, you try to do that in a coarse way, and then you make this grid finer and finer to really have the deformation at a regional level. There is another large class of techniques which are called feature tracking. And this is really similar to speckle tracking in echo, which will first define a region of interest, and it's usually the endocardial border or the epicardial border. And on that region of interest, patterns will be looked for in an image later in the cycle. And in that way, motion of regions can also be followed. Also, typically a multi-resolution approach. First, the ring is tracked, and then points in between are tracked to get a consistent tracking. So if you compare the two techniques, the first one is less dependent on a region of interest. Actually, there is no region of interest. Usually it's just the heart that is cropped out of the image to do it. We can calculate the deformation of the complete image. That means that these techniques are usually slower, but computing power is also increasing, so they become faster and faster. But the disadvantage is that you have to put constraints on the displacement field, because otherwise this could be there could be foldovers of this grid, which are not physiological. But that poses challenges also, because you cannot really put different constraints on the blood pool and on the wall, which behave anyway differently. So if you look at feature tracking, it is dependent on a region of interest. It is also dependent on feature choice. It tracks borders, or it tracks features on the borders, so it's quite fast. It's only a limited number of points that have to be tracked. And you need to put smoothing constraints on the displacement of these features. And it's always in this constraining that you have to make trade-offs to get smooth curves versus more realistic curves. There is a consensus now on how to measure global strain, and global strain should now always be reported as the relative length change in the contour. It has not always been like that, but I think most vendors now have adopted this. If you want to read more, we have written a review on this, that you can see the reference here. Why would we prefer MRI over echocardiography? And I think my answer to that would be that for the moment, if you only look at deformation imaging, and you do it with tracking techniques, so speckle tracking versus feature tracking, there is not a real difference, with maybe a slight preference for echo between the two techniques. What is different, if you look at an MRI image, and there's an image of a patient acutely after infarction, if you look at the echo image, that's the field of view that you get. And if you transpose that to the MRI image, that would be the same field of view that you get. Of course, you see similar aspects of the image, and most of the function you can see in both images. It's a patient acutely after reperfusion of an LAD lesion, and you see the thick septum, the edematous septum after the reperfusion. And the only difference you could say, and that's where echo will always be superior to MRI, is if you look at small thin structure like the valve leaflets, you will all agree that on echo you can see them much nicer than on MRI. If you open the field of view of an MRI image, of course, it's much bigger, and you can see the surrounding structures usually much better. Of course, in the echo, you would do apical views, and you would also get the information. But you see here that clearly the thrombus on the parasternal image in the apex, you would not see. But that's something else. But I think the major advantage for MRI is that you can, despite it being more expensive and less accessible, you can do tissue characterization. So you can really do different sequences, contrast enhanced, to really get an image of how the tissue looks like. In this case, an infarct, a hemorrhagic infarct. Now back to speckle tracking. What's the differences and what is the impact on speckle tracking of the two modalities? Echo has a quite high spatial resolution. It's maybe not isotropic, but the actual resolution of an echo image is quite good. We can talk about 0.3 millimeters if you look in the direction of the ultrasound. So that's good, and the reconstructions are usually done with nice interpolations. Then you get images that have a high resolution. Nothing is true like that for cardiac MRI. The only thing that is good in cardiac MRI is that you have good contrast between tissues, but usually the spatial resolution, unless you go to very specialized sequences, is rather poor. And in the most clinical images, we are talking about in-plane resolution of 1.3, 1.7 millimeters. And what is even more important, to get signal, the slice thickness is usually about 8 to 10 millimeters. So you get information about 8 to 10 millimeter thick slabs. Now, a second difference, and I'm talking now about clinically acquired images, is that nowadays on the echo machines, you get quite high temporal resolution, let's say 60 to 80 frames per second, which is at the heart rate of 60 beats per minute, 60 to 8 frames in a heartbeat, which is kind of the ideal to do speckle tracking. If you go to clinical MRI and what is usually used in the clinic, we are talking about quite low temporal resolution, and we usually reconstruct 25 to 30 phases per heartbeat, which is only half of the temporal resolution of echo. Now, what I already said, low contrast to noise in echo, high contrast in MRI. And what is good for speckle tracking is that you have the presence of patterns, interference patterns, the so-called speckles, due to the fibrous and sheet structure that was discussed by the first speaker. You don't have this in MRI, and therefore tracking has to rely on other anatomical features like papillary muscles and trabeculations, which could be less correct. Now, a lot of studies have already been done to compare the initial gold standard, which was the tagging technique, which is really more or less a gold standard in the sense that you really tag the tissue and you follow the tissue over the cardiac cycle. So that's really a direct measurement of the motion and the deformation. And that has been compared to this gold standard of MRI tagging. And if you look overall on the studies, and there are a lot of studies, and we have been reviewing this a few years ago together with Partus and Gupta and Eikenagel in this review in JACC Imaging on the use of deformation imaging, both with speckle tracking echo and with feature tracking MRI. If you look in the literature, there is always quite reasonable comparison between longitudinal and circumferential strain and the gold standard tagging and sense sequences with correlation coefficients that go around 0.75, which is not bad. The thing to remember is that radial strain is very difficult with speckle tracking techniques. With echo and with MRI, radial strain is really not comparable to the gold standard, and also intermodality, it's not really comparable. And that's true for mostly all techniques and all comparisons. So there was a very recent study that compared specifically for MRI, and you see that, again, similar results have been obtained, comparing also different vendors, which represent also slightly different methodologies. But overall, there is a good comparison with standard techniques or gold standard techniques. Then there is the other question about inter-vendor variability, which is a big issue in deformation imaging. There has been a lot of studies done for echo, which I will not review here, but there are also studies done for MRI. And one of these studies we have been doing in Leuven, where we compared 4 vendors. One vendor, Medviso, that uses elastic registration, other vendors, Circle, Tomtec and Medis, that use feature border tracking. And if you look at the curves in a variety of patients over the 4 vendors or modalities, you see that they are, again, quite similar in terms of longitudinal circumferential strain in normal patients. radial strain, you see already a lot of variation. But if you then go to pathologies, for global pathologies like dilated cardiomyopathies, it's still reasonable. But for infarcts, you see, and especially for radial strain, you see kind of huge differences that you would even interpret physiologically different. Now, this is just an overview of the differences between. I will not bother you too long with that, but we did Plantaltman comparisons and looked at it. So I told you about a more recent study by the group of Schuster in Germany, and that have also compared feature tracking techniques towards a gold standard. And the general conclusion, which is also the conclusion of many other studies, is that there is consistency, a correlation of strain values, which is independent of vendor and are good. So above 75% correlation. So that means that you can do reliable strain assessments among different approaches for longitudinal strain and circumferential strain. And there are even some vendors like Neosoft that do that fully automatically. And it seems that we are going to a real good standard, and we will be able to measure this fast, reliably, and accurate in So the absolute agreements with imaging standards can differ amongst vendors. Okay, that means that there is still some work to do and further standardization will be necessary. If we then look again at normal values, you see quite some differences in normal values between studies which have been done with different vendors. And of course, the question is, what should we do with these values? And I think the only good answer there is that for larger centers, first of all, you have to do enough of these studies, and probably you have to make center-specific normal values. I know that sounds a little bit as a stupid answer, but I think for the moment, it is the only way to use normal values in either speckle tracking or feature tracking. But there is more, and it was already alluded to by the previous speaker. I think we should also not underestimate looking at the curves and looking at comparing the responses of different components. And that's what we have been trying to review also in the JACC imaging review that I mentioned earlier with Parto. This gives again this transition from normal fiber function to heart failure, where you have transmural fiber dysfunction, and you have this gray zone where you have ejection fraction in the near normal range. But anyway, there is something going on, and you want to tease out what is going on. And if you look at the strain curve, these are cartoons, but they have a systolic component for longitudinal strain, circumferential strain, it's shortening, so it's a negative component. And then you have a biphasic early filling and late filling component. And that's true for all these deformation components, either for radial strain, where it's positive, the wall thickens and then thins biphasically. You have also twist. We will not go into that further. But you can reason, and also you can simulate it, or just by reasoning, you can see that the transmural course of the fibers, which has been discussed by the previous speakers, and which really go from longitudinally endocardial and then turn around to epicardial, where they become a bit less longitudinal, but again, more in longitudinal direction, and the circumferential fibers in the mid-myocardium. You see that when different layers are affected, like the subendocardial layer is affected, which you would typically have with all forms of ischemia. Is it because of aortic stenosis or really by a coronary lesion? You would have that the subendocardial functions become dysfunctional, and mainly longitudinal strain will be affected, and you will get a compensation of circumferential strain. The other thing is true when you have disease entering from the epicardium, then circumferential strains will be more affected because on the epicardium they are more circumferential, and longitudinal strains will compensate. So although circumferential strain has been less validated, but it has been a bit validated, by comparing circumferential strain or response in circumferential strain and longitudinal strain, you are able to get an idea of what is going on in that patient. And this is a table, but for the sake of time, I will continue a bit faster, and you can read it in the review. It's a table that shows how components are affected in different diseases. Now, saying this, probably strain for differential diagnosis will have a limited role to play. And I think strain will play more a role in monitoring patients, following up patients in their evolution to progressive heart failure, and see which components or which strain components change. Because for differential diagnosis, and it's true for a lot of the functional imaging, except for ejection fraction, there is not a big role of true deformation imaging. There will be some exceptions for sure, but I think it's mostly in the follow-up of patients in monitoring their progression to heart failure. And therefore, it's the consistency that I stressed in the previous slides is important. So for the moment, the advice would also be to do it with the same modality, with the same scanner, if you now compare things. Then to end the presentation, I have a few other applications, which is atrial strain. You will hear more in the conference about it, I'm sure. We can now measure the strain of the atrium. There are a lot of studies going on that try to understand the role of atrial strain as an independent predictor. I think, but that's more philosophical or maybe just general. Strain will have a role to play in abnormal atria that are not enlarged too much. So a large atrium will always be bad, and then probably strain will not play a big role. There is some studies in atrial fibrillation that have shown that, or an additional value. But in atria where the deformation is down and have a near normal size, there is where the changes in atrial strain can have an additional value. Now, this is just an example I wanted to show how you can see that speckle tracking makes sense. This is an example of a 32-year-old woman with a peripartum cardiomyopathy, and you see that you get really low strains at the first measurement. There was only an ejection fraction of 9%, and the patient had to get a heartmate to survive. A huge ventricle, and of course very low strain values. So the axes are not scaled the same, but only a circumferential strain of -4, which is extremely low. And then after 1 year, the patient recovered almost completely, and you see nice deformation values. So just showing that you can measure sensible things with these techniques. One thing that I already mentioned, and is probably important, is that the usual MRI images are taken at very low frame rates, only 30 images per heartbeat. And I think in order to measure other strain-derived parameters, like, for instance, mechanical dispersion, which has been linked to arrhythmias by essentially the work of Christina Hauga in Oslo, which is nice work and shows also that looking at mechanical dispersion, which is strain-derived, has some potential role for prediction. We need to go to higher images. And we tried that and learned it's possible to do it. And you see then that your strain curves begin to look more and more like the strain curves you have from speckle tracking or tissue Doppler. This is just another example that if you can go to higher frame rates in MRI, that you can also look at timing of the strain curve. This is where, for instance, post-systolic shortening can play a role, and that is in loaded right ventricles in pulmonary hypertension. It's known that the right ventricular free wall, because it's loaded much more, will contract longer, and that has implications and can be measured on strain curves where you see that the peak is delayed, and the speed of deformation is lower. So let me conclude, ladies and gentlemen. For sure, strain will have added value with respect to ejection fraction, especially in subclinical disease, and has prognostic significance. Its role will probably be in the follow-up of patients and monitoring patients in their evolution to heart failure, and to be able to come faster with corrective therapy, as has been shown nicely in the SCORE trial, I think, in cardio-oncology, where cardioprotective therapy can be started based on measuring longitudinal strain values. The current techniques are all applicable on routine B mode and cine images, which makes retrospective analysis possible. There is a fair reproducibility and similarity between CMR feature tracking technologies, but standardization efforts continue between vendors. You can measure all directions, although momentarily, I think radial strain is not good enough, is not reproducible, and should not be used for the moment. And as a last point, but we will see whether the radiologists find that useful, because, or the CMR people find that useful, an improved temporal resolution for CMR could be necessary to detect relevant additional changes. And so I want to thank you for your attention.
Very interesting topic. Any question from audience, colleagues? Някакви въпроси, коментари?
Dear Professor Klaus, thank you very much for the very elegant presentation. There is one question from the audience. How do you think, which data is possible to compare from the MRI strain delivered and equivalent for the 2D or 3D strain?
It will be used usually 2D strain, because that's what we do in MRI. In MRI, we work with slices. Of course, you can orient them differently, but now the consensus in the protocols on MRI are that there is also started from the 3 apical views, which we know in echo. So the 2D strain will be the most comparable.
Okay, and can we compare the different layer strain from the 2D images with the MRI strain data that is possible to analyze the different region?
The layered strain in MRI will always be a calculated layered strain. The reason for that is that in MRI there is nothing like speckles in the myocardium. So it's a homogeneous signal that comes from the myocardial muscle. So there is no way that you can reliably estimate layers in MRI cine images. What you have to do is very high resolution tagging, which is also not difficult. That could be possible to measure layers. But it's different than echo, where you could try to measure layers. Although saying this, I think also there is a lot of processing to measure the layers, and I don't have the feeling that is really clinically taking a big, how do you say, a big flight. So layer strain is very difficult to do it consistently. If we already think that regional strains are less validated and less easy to get numbers, I think for layers that's even more so. And we are going more and more to global strains and comparing global strain components.
Thank you so much. And so we will continue with this session, and we will back with the scientific program after 2.5 hours. Our program will continue with the workshop, which is divided into 2 parts from 2 hours. Колеги, продължаваме с практическата част, която е разделена на 2 части. Съответно по 45 минути, за да имаме време да се почистят 2-те зали, където ще бъдете разположени на компютрите, тези от вас, които са заявили участие за практическото упражнение. Всичко това ще може да се наблюдава също тук и в залата, само че без да работите на живо с екопаците. За съжаление ще бъда само аз в практическата част. Имахме желание професор Сенгупта също да се включи с практическите упражнения, но поради затруднението, което ще бъде онлайн, за това ще бъда само аз тук. Така че след 2 часа ще продължим и с един от спонсорите на нашето събитие, с симпозиума на фирма Fibre. Продължаваме имате време да се преместите тези от вас, които желаят, в зала Вихрен и зала Леко, за да се продължи към практическото упражнение.